This conference will
Hello.
now be recorded. This conference will now be recorded.
Okay, there we go. Welcome everybody. Today is February 13th, 2024. This is our AnCan Advanced Recurrent Prostate Cancer Group that meets 4 times a month. This is our Tuesday meeting, which meets a little bit earlier on Tuesdays. And welcome everybody. My name is Peter Kafka, and as you know, I'm moderating from sunny Maui, Hawaii. No complaints about living here, other than the doctors are kind of junk, as they say in Pidgin here. How was the meal? Junk. How are the doctors? Junk. How is the surf? Junk. Anyway, I shouldn't be moaning that. Actually, in a couple of weeks, I get to meet my brand new oncologist here. I have to give her the benefit of the doubt. She is actually a GU medical oncologist, amazingly enough. Maybe I think the first one in Hawaii. So I'm happy about that. No, I've met her already, but I haven't seen her as a patient yet. That's going to happen a week after next. Julian, greetings. Do you have anything tonight you want to bring up?
No, sir. I'm just listening. Thank you.
Okay. There was a gentleman who, actually a vet, who showed up at the last minute on our low and intermediate call last night, and I pushed him over to this call. Hopefully he'll join. His name is Rick McCollum from Arkansas. We don't get many guys from Arkansas, but like Maui, there's not great medical care there, but we'll welcome him if he is a new person and he does join us. Okay, a word of thanks to our sponsors, which you've all heard mentioned, but I'm going to mention them again. Bayer, Pfizer, J&J, Johnson & Johnson, Sumitovant, Blue Earth, Myriad Genetics, Foundation Medicine, and Telix. As I've often said, we're not beholden to them, but we are certainly very thankful for their generous support and their recognition of the value of peer support. As we all know the value of peer support, it's great to see that the pharmaceutical industry and the medical industry and the doctors themselves are more increasingly understanding and appreciating peer support. I recently had an experience accompanying a friend of mine to an appointment with a local radiation doctor who I knew, and I'm really glad I went, because this guy was a nervous Nelly, and he couldn't hear a word the doctor was saying, and the doctor was telling him, hey, you've got a good option here of doing nothing. And this guy was, he went in with the attitude of, I got to get this taken out. Someone who does cryo on Oahu, and he wouldn't stop at anything to get this cancer taken out. And finally, he heard the doctor say, let's wait a while. You could live a long life and not go through the trauma of treatment right now. Let's wait and see and watch this. And so. And the doctor wrote me back and thanked me for what I did. And I don't often get that. And, many of you are probably beginning to receive that too from your correspondence and your accompanying guys to appointments and so forth, or letting your doctor know you heard it on AnCan, and the doctor's actually being appreciative. We had a guy last night on our low and intermediate call who came because someone
really runs a risk of, what kinds of families can afford.
Excuse me?
I got him.
No, we muted him, Peter.
Okay.
That was somebody coming in with a.
Yeah, we had a guy last night who came because his doctor suggested he come on to our AnCan support group. I don't know who that doctor was, but I should have asked, but I thought that was an interesting thing, that he was directly sent to us as a new person because of a physician. So we're gaining steam, gaining notoriety, gaining appreciation, getting some And we've always known we had credence, but it's good to know or recognize. Cliff, welcome. Do you have anything tonight? Tonight, Cliff?
No, I have nothing tonight. Thank you.
Okay, well, welcome. Okay. Well, we don't have many people that want to speak, but as always is the case, we will fill the time up, I'm sure. We've got some good stories. I've got some as well, and I'll stick myself in someplace with some interesting stuff going on. So let's start with Mark. You said you had an update.
Yeah, I just looking to see if anybody's got any ideas. Just a quick recap. I discovered 5 years ago that I had cancer. It was 5+4 Gleason. I had 3 years of ADT. I had 6 weeks of radiation. And then in 2022, I started a drug holiday, went a year and a half, and then found out in November that the cancer was back and that I had a bone metastasis. So I'm back on ADT, and I had just a radiation for that bone metastasis. But the thing that's different this time is the fatigue is a whole lot worse. And the brain fog is a bit worse, and Jimmy's not here, I don't think, but I'm really having trouble keeping up with any kind of exercise. I started out like walking half an hour, and then it went down to 20 minutes. And yesterday I walked 12 minutes and I was exhausted. And just wondering if anybody has any ideas what else I could be doing wrong. I'm getting all the blood tests. We don't see anything wrong, but I feel terrible.
What's your hemoglobin?
I don't have a figure in front of me, but it's all okay.
Mark, which drugs are you taking now?
Xtandi and Lupron.
That could do it.
Well, that'll knock you
Get off
out.
get off the
But
Xtandi.
like I said, I had 3 years of it and it was never this bad.
Well,
But
Xtandi kicked my butt.
Xtandi is notorious for fatigue. Of the 4 drugs, Xtandi probably gets the worst rap when it comes to fatigue. So our suggestion, well, I should say my suggestion, but I think the guys will agree with me, is to get off the Xtandi, see how you do on darolutamide. And it'll probably make a huge difference. If that doesn't, then, if you're still feeling terribly fatigued, try abiraterone and prednisone and see if that helps you. But
I started out on that and I had bad reaction immediately. So that's why I switched to Lupron and Xtandi.
Okay, well, I'd get off the Xtandi and move to darolutamide. There's a number of people who have found on this call, and they'll speak up right now, who have found that switch to be beneficial. Who's gone from abiraterone? If you put your hand up, then Peter will call on you. If you've gone from
I went on. I was on abiraterone for about 2.5 years, and it really had major effects on my heart. I talked my doctor into letting me get darolutamide, and last 2 months I've been on it since August, and the last 2 months I've been undetectable for the first time in 6 years. So it really works for me. And the heart issues, the other issues that abiraterone caused are gone. I'm in much better shape.
But isn't Xtandi enzalutamide?
Yes, but darolutamide is much lower side effects than enzalutamide. That's one of the reasons many of us are moving to darolutamide from whatever we're on, because the fact that the side effects are so much easier on the body.
Darolutamide is known as Nubeqa. That's the trade
Yes.
name. Okay, Alan Babcock, you've got a comment.
So I can't talk to the medications because I'm ignorant about them. But one thing you might want to consider is trying a different kind of exercise, because walking, you're carrying.
Hold on a minute, Alan. Alan, let's just stick with the and we'll come back to you. Let's just stick with the darolutamide, enzalutamide abiraterone.
Okay, David or Frank, either of you have comment on that subject?
Hey, Mark, I was on enzalutamide. My life was upside down. I had no energy. I wasn't functioning. I got off it, went on darolutamide, and it was like day and night. I
Okay.
experienced the exact same thing you did.
No, I did all right on it the first time, so I was a little surprised that my reaction's different, but
They're cumulative. This
total
stuff piles up on you.
I was
Okay.
not functioning. Darolutamide did the trick.
Frank, did you have a comment on that?
Yes, I was on first line Relugalex, and second line was enzalutamide, and I was having dizzy spells, tremendous fatigue, and pretty heavy brain fog. And I switched to darolutamide, and I had half the side effects that I had on enzalutamide, but then I had to switch off of that because my PSA was starting to rise. And then I switched to abiraterone and prednisone that I'm on now. But certainly when I switched for almost a year and a half, it was very beneficial to me.
okay.
Well, I can't remember who the manufacturer of Xtandi is, but I hope they're not one of our sponsors. But I know
It's
Bayer's
Pfizer.
one. Huh?
It's Pfizer, Peter.
It is Pfizer. Okay, so you got it. You got Pfizer, and also
It doesn't make a
Dr.
difference. I mean, let's just
Yeah.
make it real clear. You know, let's not talk about sponsors in the same context as of the drugs,
Right.
because we're really committed to providing peer response. Whatever the peer response is what it is, and we tell them. Plus the fact that most of these sponsors don't want you promoting their drugs anyway. So if it's good, it's good. If it's bad, it's bad. How about Herb Courtney?
Yeah, I was on Lupron and Xtandi, and of course, you get the hot flashes from the Lupron, but the Xtandi was given me, well, as I found out later, really bad fatigue, leg cramps, exacerbated restless leg syndrome. And I switched from Xtandi to darolutamide with Lupron, and all of that went away. Now, subsequently, I've gone off the Lupron, and just on darolutamide, but I basically have no side effects.
Okay. I'm seeing a trend here.
These drugs, while they consider them similar, they're not all the same. I mean, they have different formulas, and the doctors sometimes, just grab one thinking that they're all second line antiandrogens, but they are not the same. So,
So one thing that you might want to raise with Dr. Borno is the possibility of trying a monotherapy darolutamide, because David's on monotherapy darolutamide, Herb's on monotherapy darolutamide. Who else is on monotherapy darolutamide? Len's on monotherapy darolutamide. More and more, we're seeing some really good docs. Dr. O, Dr. Shmulewitz, Dr. Reddig at UCLA. They're all willing to try monotherapy darolutamide, and she's forward thinking enough that maybe she'll try it with you, and you'll feel a heck of a lot better on monotherapy darolutamide, and see how you do. Worst that happens, you have to reintroduce the LHRH.
Yeah, I got to work on her a little bit. She was reluctant to switch me to darolutamide, but I think she's so busy, it was too much work for her. But I got to go back and push her.
That's not a good excuse, and you have to tell her that.
Right.
Seriously. I mean, I'm really serious about that. I mean, we can't have the docs running there if they take on their patients, they've got to do the best for their patients. We know from this group that the best for the patients in terms of hormone therapy, what they tolerate best, I'm not talking about best results, what they tolerate best is monotherapy darolutamide, and for some guys it works. And we've got 3 or 4 guys in this group tonight that it's worked for.
Right.
Okay.
And these drugs do kind of compound. I mean, even though you didn't have much effect the beginning of it, the second round, it can pile up on you. I found that. I mean, even Lupron piles up on you if you have to go back on it and stuff. At least that was my experience anyway.
Okay.
Alan, you had a comment about activity.
Right. I was going to throw out that, walking is weight bearing. You're bearing all your weight. It's great if you can do it, but if you can't do it, you might look for something a little different. Stationary bike where you're not bearing all your weight. You might be able to get more exercise that way. Or there are bikes where you're just moving it with your hands. So I'll just throw that out. That may give you a chance to exercise without fatiguing so quickly. It's not based on any research. It's a guess.
Yeah. I'm trying some other things.
Finding a buddy too.
I've got home health care that comes in and has got me just doing some simple exercises, standing at the kitchen counter and all. And I get exhausted after 15 minutes of that. But
well, yep. So maybe that's just right. You got to work on the medicine.
Maybe ask the home health care person if they'll take a walk around the block with you or something. I mean, exercising with somebody else, with a buddy, can sometimes spur you on too.
No, it's just after 10 minutes, I'm getting so tired, it's getting dangerous. I'm not picking my feet up enough. I'm afraid I'll trip on a curb or something. But
yeah.
Anyways, you guys gave me a lot to think about. Thanks a lot.
I was wondering if your T level came back up during your drug holiday.
Yes, it did. Not all the way up, but like in the 300s, I think.
Oh, well, that's good. I suppose it's crashing now.
Yeah. Okay, well, thanks a lot.
Okay.
Hey, Peter, I have a question, if you don't mind, for Frank Faber. She said his PSA started rising on Darrow, and then he switched to Abby. So what happened since then, Frank? Did your PSA drop down?
No. It held steady for 2 months, and then 2 weeks ago, it tripled. Even though it's still under 1, it tripled from 0.33 to 0.97. And I have, which I was going to talk just briefly about, tomorrow I have a PSMA scan to find out has it metastasized any place else other than my lungs.
Well, go ahead and take the floor. Go ahead and keep the floor then.
Okay. My quick message was I have my PSMA tomorrow, in which my doc wanted to find out if it had metastasized any place else except for the nodules in the lungs. And I have that first thing in the morning at 7 o'clock tomorrow morning. And then at that point in time, I have a follow-up appointment with my doc on Thursday to discuss the scan results. And then we'll discuss treatment and what's going to happen. And one of the drugs he's going to be talking about most likely will be Pluvicto. And I had a chance to listen to the podcast of the 2 docs, and it was led by Dr. John on radionuclides, and Pluvicto being one of those. And it helped a great deal to fill in some background on Pluvicto and its results and possible side effects. And also it included a group of other radionuclides, which I found helpful because I had questions about the Pluvicto, its effectiveness, and the side effects. I also contacted the guy who started. He started. Let me see what the name of it is. The PC Tribe. Even though I don't participate in their Zoom calls, the guy that started it, Tracy Morgan, has been on Pluvicto, and he's been castration resistant, and he's on his 4th treatment, and it has been effective of bringing his PSA from upwards of 300 down to under 10. So he's found it very effective, and his side effects that he said he had are pretty similar to the ADT drugs that we're taking right now. So anyway, I'm going to have that news on Wednesday and Thursday, and then hope to arrive at a decision of what my change in treatment's going to be.
Frank, when was the last time you had a PSMA scan?
I had it 2 weeks ago.
Oh, very recent.
PSMA or PSA?
PSMA.
This is the first one that I've had.
Oh, the first one you've had. Okay.
Yeah, the first one, the first test that I had that defined the metastasis to my lungs was an Oxyman PET scan. And that was done in September of 2020. And that's when I knew that my cancer had gone metastatic, was at that time. And it's been under control since I went through chemo in the first 3 months of 2021. I've been down at undetectable since that point up until 6 months ago. And now it's steadily bumped up, and then last 2 weeks ago, it tripled up to 0.97.
Hey, Frank, this is John. You know, we've been often bringing up the topic when somebody's doctor is considering Pluvicto of not only getting a PSMA-based scan, but maybe also an FDG-based scan to see whether all your lesions are in fact PSMA avid. In fact, Rick and I were asking Dr. Qua recently in that seminar about that very question. I assume you just got the PSMA scan, right, and not a accompanying FDG scan, right?
Right now, my PSMA scan is scheduled for tomorrow morning.
Okay.
And then I meet with my oncologist Thursday to discuss the results. And I
would go back to your oncologist and say, I want a FDG scan before I meet with you.
Okay.
The problem is this. These docs are not taking this concordance seriously. And it's all very easy to get it approved in this country. But God forbid, some of your scans, say 50% of your scans are not avid, we've got to decide if this is the right treatment. And we need to know it before. And Mordasavi should be ordering an FDG scan. Now, if you followed in that discussion, which was very politically correct between the two doctors, the radionuclide doc said, oh, no, you don't need an FDG scan. And Dr. Sartor waffled. And then I jumped in a little bit later and I raised it again. And Dr. Sartor said, yeah, I definitely think you should be looking at that because this is what they do in Australia. It's protocol in Australia. And at that point, Dr. Kuo said, yeah, you probably do need it. Why? Because the PSMA is going to show lesions that make PSMA. The FDG scan, hopefully, is going to show lesions everywhere, whether they make PSMA or they don't make PSMA. If we find a bunch of lesions in Frank Fabish, God forbid, that don't make PSMA, you got to sit down with Dr. Mortasavi and figure out another plan. And we don't want to do that after you've been through 6 rounds of Pluvicto and you didn't respond. And so if it were me, I would be calling Dr. Mortasavi and saying, Dr. Mortasavi, I'd like an FDG scan as well to compare, at which point let's sit down. Please can you add an FDG scan tomorrow or as soon as you can?
How long ago did you do the Oxyman scan?
I did that in September of 2020.
A long time ago. Okay.
Yes.
Yeah, I mean, these scans, the FDG and the PSMA for concordance need to be done pretty close together. Maybe I would say at the most, I'm not a doc, but my feeling is 3 months at the max is sort of pushing it, because the disease moves quickly and changes at this point in time. And since you haven't had an Axumin or an FDG, but the Axumin might cut it as well, Peter's right, but you need a scan to see where all the lesions are right now. An FDG or an Axumin, probably, I don't know. I don't know which is better, but you need another scan. And you don't want to be sitting down with Mortasavi until you have all the information. That would be the way I would do it. But, other comments? I see Dennis has his hand up.
Yeah, Frank, what is your current PSA?
0.97.
0.97?
Yes.
And then the other question is, what's the sensitivity of the FDG scan from a PSA standpoint? That's kind of low.
I don't know. Does anybody know the answer to that? It's a very good question. It's never really come up. Len, should the PSA be a factor in an FDG scan?
Certainly, if the PSA is rising quickly, FDG is indicated. But even if it isn't, FDG is still appropriate, because whether or not the cancer cell is producing PSA, if it is growing, it'll be taking up glucose to a much greater extent than your other cells. So that's why we call it a metabolic scan. It's radioactive glucose. So if your cancer cell is growing rapidly, it's going to be picked up by FDG, regardless of if it's making PSA or not.
Early in my treatment, I had a PSMA scan followed a week later by an FDG scan. And when I was told it was strictly to find out if it was hypermetabolic, that's when they were trying to determine if I had metastatic cancer or not. But that was the pulmonologist's choice, rather than doing a Axumin or something else. He went right for the FDG.
Frank, do you follow the rationale that we're putting forward?
Yes. I will present that to him tomorrow and ask for a follow-up FDG scan before we move ahead with any change in treatment.
And keep us posted.
Yes, will do.
Okay. As an aside, I don't know if noticed in the for this meeting, I had a short piece in the reminder notice saying, ask for the discs. I mean, these are yours. And it comes in very valuably to sometimes compare discs. If you're PSMA, but if you have another PSMA done a year or 2 years ago or 3 years ago, to have a disc and ask them to compare it, because oftentimes all they do is compare the reports, and the reports don't really look at the two things at once. So if you could walk into when you're getting a scan with a disc of your last scan and ask them to compare it, they'll put it on the report, the actual comparison, whether your Mets are decreasing or increasing, or whether there's new things showing up since the last one. It's worth doing that. So just tell them that you want a copy of the disc, and if you have to wait 20 minutes afterwards instead of running out, wait and get it in your hands as you leave.
Peter, can you get those discs after the fact? In other words,
yes.
Let's say I had a PSMA a year or two ago. Can you go back and get those discs?
Usually, yes. So you just talk to the facility. They have a place where if it's a hospital, they'll have the radiology center and just ask them if you can get a copy of it. And they don't charge you usually. They'll give you one or two. Yeah.
Thanks.
Yeah, handy things to have. Because if you have to, as I said, if you have to ask the institution, just like a biopsy, asking for a second opinion, you got to lean on them and remind them. And, sometimes the clerks say, oh, yeah, it's kind of at the bottom of the pile here. We'll get to it. We're just busy right now. But if you have it in hand, the radiologist will look at it immediately. Okay, Frank, good. We wish you luck on this one. I'm glad things are still low. We're climbing, so a little bit similar to me, but I'll get to me later on. Okay. Okay, Don Rogers.
Yeah, hi everyone. Just want to give you an update. 3 weeks ago, Rick and this group suggested that I switch oncologists because mine was just basically a generalist, and they, of course, there's this need to have a GU oncologist. So yesterday, I switched oncologists and met with Dr. Bilusic down at the University of Miami. And we had one of the big questions is that I'm 20 months into ADT, and whether or not I can stop it at 2 years. And he said unequivocally, yes, that's his standard. He stops at 2 years and he'll see what happens after that. He was very encouraging. I feel the best I've felt after a doctor's appointment in a long time. But so thank you very much for the suggestion.
That's great.
Great.
Just saved yourself 6 or 12 months of ADT.
It'll be 24 months altogether.
Yeah, but you were originally being told 36 or 30 or something like
36, that. Right. I was originally told 36, and in my former oncologist was very hesitant to suggest that I could be less than that. And I tell you, I tore through the literature. I could not find one thing suggesting that 3 years is superior to 2 years when you have the dual therapy.
Right. Well, good for you for changing. Anybody else?
Bilusic
have any comments?
Bilusic told me the same thing yesterday, and he has a way about him that's very nurturing and very supportive and very healing. So that's why I'm glad you had that response.
Not to mention he's an NIH alum, Dr. Jack.
I know.
Did you wear your NIH T-shirt when you went in to see him?
He knows all about that. We talk that all the time about people we know.
Look,
Marshall.
Let me just say, we have consistently gotten great responses on Dr. Bilusic since he moved down to Sylvester from the NIH about 2 years ago. and he was really needed because we did not have a go-to GU medical oncologist in South Florida. There's another guy who he practices with, but he spends half his time in India, and I don't think he keeps up well with what's going on. And so it's music to our ears that when we're shifting people to Dr. Bilusic, that they like him and that he gives good advice. So we're thrilled to hear it.
And good that you got an appointment that fast. That's great. Good for you.
Thank you.
Jim Marshall, go ahead.
Don, I think you said dual drugs or something.
Yeah,
What is that with the second drug?
Abiraterone.
Okay,
L-guard.
abiraterone.
Yeah, an abiraterone.
Don't forget about the
and prednisone.
prednisone.
Sure. Yeah.
Okay, the prednisone and getting yourself off of it slowly. Don't just stop it overnight. Have a
We
schedule.
talked about that. I talked to Dr. Bilusic yesterday about the taper, and he says it's got to be at least a 3-week taper off from the prednisone.
Okay, at least 3. I did like 5 or 6, just for grins.
Yeah, we've seen some guys manage on 3, but we've also seen some guys not do too well on 3. Gary Peters probably has something to say on tapering off of prednisone.
Do you, Gary?
And I'm unusual because I'm taking 10 milligrams rather than 5.
Yeah, for sure you want to taper then. Cut it down to 5, cut it down to 2.5, just go slowly. Okay. And everybody knows
is Gary with us? He was. Maybe he had to drop off for a while, but he's had a bunch of issues with coming off of prednisone.
I don't see him on there.
No. Just be careful.
Yeah, I was just going to ask what the ramifications of tapering off too fast are.
Oh, you don't want to know. I mean, I had one buddy who they completely forgot to tell him, and he was with a world-class GU medonc. It just slipped through the cracks. He finished up losing 30 to 40 pounds and felt absolutely awful, fatigued, and really rubbish. And it can be pretty nasty if your adrenals don't wake up. They get shocked into going dead, basically. Anybody had experience in this group right now with that, or?
I have, but it's recently, and I've gone on and off prednisone probably 3 or 4 times over the years, but sometimes it can just hit you by surprise. I'm going off right now, actually. I stopped yesterday, but I tapered off, and I was on 40 for 40, 30, 20, 10, 5, 2.5. It's you got to watch it. Okay, well, thanks.
To be forewarned is to be forearmed, right, gents?
Yeah.
Yeah.
Okay. So someone who joined late on the call, Rich. I just want to make sure you're not the Rich who was on the call yesterday from Arkansas. Is that you
Nope.
or is that somebody else?
That's not me. I'm in Bar Harbor. I'm listening and just observing. Thank you.
Okay. Do you want to participate at all?
No, thank you, Peter.
Okay. Good enough. Okay. Okay. Steve Schuler.
Yeah, status update. I haven't been on the call in a while. So last year I had been trying to convince my doc to do a secondary agent, and my doc got booted upstairs. Dr. Yu is now director of oncology, and my new oncologist, who came from Dana-Farber, is Rajitha Sankara, and I like her. And I had the discussion with her, and she agreed to put me on abiraterone. So I started that a few days ago with prednisone 5 milligram, and so far that's been going well. So that's my update on that. Other than that, everything's been going pretty well. I had been suffering from erectile dysfunction because I had my nerves cut, and I've had the prosthesis surgery last October, and that went really well. So I have positive things to say about that. If anybody wants any details about that, I'm willing to talk to somebody about it. But so that's my status update. Things are going pretty well.
Yeah, I would like to hear a little bit more about that because, we've had a few people with artificial urinary sphincters put in, which also has a little pump in the scrotum, but I don't think we've had any of us describe what sounds like a scary procedure.
Yeah.
But it worked out fine, huh?
Yeah, I have positive things to say about it, and my doc. I think she did a good job. So.
Where are you? Where do you live?
Seattle.
Oh, okay.
So she's affiliated with the Dr. Heman, or Heman, but it's spelled Hehemann, and she's affiliated with the University of Washington and Fred Hutch.
Mm-hmm. Do you get to activate it right away, or do you have to wait a few weeks after
Wait a
surgery?
few weeks. I think it was 3 weeks, and there was a tiny bit of pain for the first few weeks, several weeks maybe. That's gone away, and it works really well.
Oh, good.
Interesting. And the Dana-Farber, did you go to the East Coast to see this doctor, or they have a Dana-Farber?
No, they hired her away. Fred Hutch hired her away from Dana-Farber, so she's at Fred Hutch now.
Okay, and how do you like her?
She's good. I've only seen her once. I'm gonna see her again in a few weeks for follow up on the abiraterone, and I'm also getting a DEXA scan. Had one like a year ago. I'm getting another one just a couple of days before I see her. So I'll see her again in a few weeks.
You might be careful that your insurance will pay for it because sometimes they have a 2-year gap between DEXA scans.
Yeah. So I don't know if you'd call this gaming the system, but I wanted a DEXA scan after a year, and so the way I think it's been justified to my insurance is because I've had a hip replacement that slightly increases my risk. So as a tip, for any of you who want a DEXA scan, if you happen to have some hardware, so use that.
Okay.
So the other reason is because I think that if you're on active hormone therapy, that 2-year rule is waived. It's 2 years if you're not on hormone therapy, is the minimum. But if you're on hormone therapy, that they should allow it more often because of the risk from the hormone therapy. The other thing I wanted to say is that it's great to know, Steve, that you have the prosthesis, because we haven't had someone with a prosthesis for quite a while. There are a couple of long-time participants in this group who will remember Jim Harrington, who had a prosthesis and a AUS, and he was always our go-to guy. If someone came on, he was very accommodating. He loved to talk to people. He was really, really helpful. And I don't think we've had anybody since then, right?
Nobody's brought it up anyway. Nobody that's brought it up, to my knowledge.
Yeah.
Yeah,
Yeah, Jim Harrington, Caressisol, was a professor at Rutgers, and he was the guy who invented the technology for laser surgery. He was an electrical engineer, and he was the one who came up with the technology for laser surgery, if I remember correctly.
Yeah, amazing
He
guy.
had the patent, or Rutgers had the patent. So
yeah, he went through about 30 chemo treatments. Amazing
oh
guy.
man,
yeah,
he was a good guy. He was very nice guy.
Well, thank you for sharing that, Steve. And
yeah,
well, for sure, I'm sure we'll keep that in mind. But I'm sure people will want to know a little more of your story there, because
yeah, sure. I mean,
a lot of guys, including myself, just give up. When your nerves are cut, that's it.
Right.
You just think, well, that's the end of the sex life for me. But good for you for going that direction.
Very brave of you.
yeah. I mean, going in to decision for surgery or whatever, knowing that was a possibility was one of the factors. And then I figured afterwards I could just put off that decision. And what I found out was that there's kind of a use it or lose it principle. So if you don't use it, you will lose it. So there's a bit of a time sensitivity in terms of making a decision. So that was the factor of the timing.
I'm surprised more doctors don't have that discussion with guys before surgery.
I did not have, nobody discussed that with me going in.
Right.
So yeah, I mean, just another example of how there could be improvements to how our problems are communicated to us.
Yeah, women, it's a no-brainer to have discussions about breast reconstruction. I mean, I don't know a woman who's probably had surgery that didn't have a discussion about breast reconstruction, but this is never brought up for men and with urologists.
Yeah, so my medical oncologist, he didn't bring it up until I brought it up with him. And then once I brought it up with him, he sat down with me and said, okay, here are all the options. He referred to me as sexual specialist. And, I went the trimix route, but it was the same kind of thing. So, but I had to bring it up first. So I'd tell any guys that, if this is an issue for you, bring it up with your doc, your medical oncologist.
Right. I brought it up, in fact, and my urologist, my surgeon, referred me to Dr. Heeman.
Your surgeon told you for sure he couldn't do a nerve sparing procedure on you?
Right. Yeah.
I'd also like to give a shout out to your partner because I'm sure that the partner really has to be very supportive and committed to this as well. And I think we should acknowledge that in this group and recognize that.
I agree, Rick. Actually, it was my wife who said, "Yeah." I said, "A needle? You're going to give myself a needle in the penis?" I don't think so. She said, "Yes, you are." And as usual, she was right. Best thing I ever did.
Correct. Yep. Yeah,
Just one, can I add one thing, Rick and Ellen? We talk a lot about this stuff at Men Speaking Freely every other Thursday night. So we really get into this. And if anybody wants to talk about these kinds of issues, we really have open discussions on Men Speaking Freely. So please join.
Yeah, I
And
have not joined that group, but if somebody on that group wants to talk to me about my experience, I'd be willing to do that too.
thanks, Steve. Yeah, and I just want to give a shout out here to Dr. John and David and Rich Jackson because that group flourishes, and it's not only, it's mostly prostate cancer men, but it's not only prostate cancer men. And if you know anybody who is living with a chronic disease of any sort, encourage them to join. It doesn't have to be prostate cancer. It is a great group, expertly moderated, not by me. And and the next meeting is this Thursday at 8 o'clock Eastern in this room.
Okay.
Thanks, Rick.
Okay, guys. Thank
Free
you.
and drop in, by the way. And we don't record it. Should add that. We do not record it.
Probably smart. Okay.
Thank you, Peter.
Okay. Kurt, you said you had something you want to bring up.
There we go. Quick update. Well, first of all, it's my birthday tomorrow too, so
Oh,
yeah, so another special day. I turned 70 actually. I had my PSA test end of last month and end of January. It's been a year since my last 6-month Lupron injection. And my PSA is still undetectable, and my testosterone is risen to 40. So on the way up, but it's slow riser. So still having hot flashes, not as bad as they were before, but still there present.
Good to hear.
yeah,
It's 6
undetectable.
months, did you say, Kurt, since you...
Yeah, I had a 6-month shot in end of January. And so it's been 6 months since the end of the 6-month shot.
Right. So it's 6 months since it wore off.
Technically, yeah, theoretically, yeah.
You know, and how long were you on for before it wore off?
14 months total.
Yeah, I mean, I was younger, but I really didn't see anything for a good 6 months. It really was, it was August. I came off of it. It wore off for me around, I think, February, and I started to see some movement in the August. So it's not unusual.
Yeah, I'm not discouraged. I'm
okay.
Actually encouraged that it's double digits now, and maybe we'll get triple digits next time, or higher, double it. I don't know, but in the right direction. I'm happy.
Good. Yeah, and you're undetectable. Good for you. Oh. What? Yeah, Good for you. What had your PSA been? What had it climbed to before you got on treatment?
Only to about 3.5.
Okay.
After prostatectomy. So before prostatectomy, it was 26. After prostatectomy, it rose from 0.2 to 3.5, and then radiation with ADT, just Lupron.
Good. Well, keep it up. Wish you well.
Yeah.
How often do you do blood tests?
3 months.
3 months?
Quarterly.
Okay, good.
Yeah.
Good.
Yeah.
Nice response to treatment.
I don't know if I mentioned this in this group or not, but it's something I would encourage men to do who are still going through radiation treatment. So every time I had a radiation treatment, so I'm on Lupron, of course, and so I imagined the cancer cells in my body as fish on a dry beach that didn't have water, which was the ADT was depriving them of water, and then the sun shining down on them, which was the radiation. So that was a daily visualization that I went through with every radiation. So I think that helped.
That's a good one. And hopefully they don't start smelling.
Yeah. Well,
it's a good way to think about it. Yeah.
Yeah. Something to pass the time by when you're under the gun. So.
Right. Yeah. Well, thanks. Okay. Alan, you had something you
Yeah,
want
so
to talk
I
about?
just want to bring up something real quickly. Medicare required me to see an MD, and I was seeing a nurse practitioner. So I went to see a geriatric MD because turns out people think I'm old. It's kind of upset me a little bit, but it happens to be true. And I was shocked by how thorough an evaluation she did. I mean, after the meeting, I said, yeah, I want to keep coming to you. But what was so important is she went through this real big interview and she was asking about the support. So I told her about AnCan. She had not heard about AnCan. She thought that was the best thing she had ever heard of. She's like going wild with it, falling over herself, thanking me for this information. And I'll tell you, I also belong to a support group that comes out of Fox Chase, and I love Fox Chase, but their support group is not very strong because it's just lectures. So people don't get to talk at all. So you don't get to really, well, I ask questions, but most people don't ask questions. So my point is, if you're seeing a geriatric oncologist, you may want to mention AnCan, because she took down the website and she said, I'm going to give this to, people that I see. I said, go for it. That's exactly why it's there. So another way to support people, because I see and talk to so many people who don't have support. And, I think a doc telling you to do it is awfully helpful. So I just wanted to put that out there.
So,
well, thank you.
Yeah.
Thank you.
Alan.
And,
go ahead.
It's funny that you raised that. I mean, coincidental, serendipitous that you raise it, because I was fortunate enough to be selected for a cohort at my alma mater, Chicago Booth, earlier this week, or last Friday actually, of nonprofit board leaders. And I had a brief 30-minute entry interview today, and I was asked if I had one objective to get out of the meeting, what was it? And I said to try and raise the profile of AnCan, because the one thing that stops us from expanding is people not knowing about us, not so much in prostate, but certainly in other areas. And as David Muslin will tell you, when we expose what we're doing at AnCan to the outside world, we usually get very good response. But we haven't quite figured out how to make this secret an open secret. So we thank you very, very much for doing that. We have one thing that stands in our way greatly is the unwillingness for nonprofits to collaborate. Because what we do know is we probably have best practices and the best format for a support group. We probably run a support group for any condition better than anybody else. One of the reasons for that is we separate education and support. We don't mix these education sessions with the support sessions because some people want the education and they don't want the support, and others want the support, they don't want the education, and we think the two don't mix. So you've noticed we keep them separate, and we will always continue to do that. That's part of our best practices. But we could probably help Fox Chase run a very good group, but they don't want us. So and this is very much the story of our life. But the board, which is David and myself and Bill Franklin, we're very open to suggestions. So you can email us anytime with any thoughts, and we'll adopt, and we'll do our best. We'll at least discuss them. I won't say we'll adopt them. We'll discuss them. So, right, David?
Right. So Rick and Dave, before Rick started speaking, when Alan was bringing this up, thought occurred to me. So some of us have business cards. Rick, I still have business cards. David, I give them out all the time. But what'd be really helpful is to invest a small amount of money in a 3-fold glossy flyer, just about AnCan, something you can give to people that with the pertinent information in it and some pictures and so forth to publicize this, because it comes up. I mean, I meet people constantly, every day, doctors and other people and health professionals and nonprofits. And it would be really useful to have some kind of 3-fold flyer that is more, really to the point of what AnCan does and how to get on calls and the different calls we have and so forth, and some comments from people how it's changed their life. People like Tom about how they changed doctors and it changed their whole approach.
Right, but I have to ask a question, Peter, which is, don't you think in this day and age, and this is what we see much more often, people would just rather go to a website. They don't want the paper anymore. So I think from the standpoint of the older folks who are still used to paper, I can see it. But I think that's not where we're moving. And we print these things up. We've done it before. And we don't get rid of them. I mean, if somebody wanted a flyer of what we do, we have it. If you'd like flyers of what we do, just ask Alexa and she'll send you a file and you can print off as many as you can.
Are they three-fold? Narrow?
No, it's just a straight
page. Big page, yeah. That wouldn't work for me, but something that's compact. My girlfriend published a book. She's got bookmarks with her website on it and so forth. And she's given out all the time and people read her book. I mean, something that we can easily hand out would be very useful, I think, from my standpoint. Maybe I'm in old school or whatever, but a lot of people won't remember the website, won't write it down. But if they have it in their hand, they might.
And can you give them a card? Do you give them a card?
I always give people cards, yes. What they do with it, I don't know, but I give cards away. But something with a little more information. So I'll send you an email. I'll send an email. I had a conversation with Bill Franklin the other day. I'll talk to him again and put it out there.
Yeah, send it to Bill Franklin.
Okay.
If Peter, you may have missed what Rick said. He said they have one that they can send to you, and you can print it out on your printer.
That's a full page. That's a full page. I'm not going to walk around with 8.5 by 11 stuff. Something I can put in, have in a book that I can just pull out and give to somebody, which is a 3-fold, a narrow thing. It's easy to manage. Something someone could slip in their shirt pocket or their back pocket. Just saying. We don't have to have a long discussion about pros and cons of it. Just came to mind while Alan was speaking that it would be useful.
What kind of card do you have?
I have an old card that says I'm a moderator.
Oh.
You don't have a card, John?
No.
Speak to the boss. Get cards. You need cards.
Yeah. They're easy. Talk to Alexa, and we'll order them. We order them through Rich Jackson. Just let Alexa know. With pleasure.
Okay. Yeah. Okay. David G. in Teaneck.
Yeah, I have a strange thing that's going on. When I finish I have bad arthritis in my right hip. And when I finished my radiation treatments, it seemed to get worse. And last week it got so bad that I decided to go see an orthopedist. And now he's recommending that I have a hip replacement. I'm wondering if anybody has had any experience with this or if it's just normal.
I had mine
What
done
kind of
in
radiation?
October.
I had 39 spot radiations because I had it in my pelvic bone. And then they did my whole pelvic area because just in case.
And they're sure that this arthritis is not metastasis related.
Yes, they're sure.
Okay. Okay, Rick, I know you've had hip replacement.
Yeah. This is a tough one because we don't know of the cause and effect. We do know that. How much hormone therapy have you done, David?
I've been on it since Labor Day.
So that can be a factor. It's not that long, but it can be a factor, especially if you're weak, if you have weakness in the hip. I have 2 hips. I did 2.5 years, but I was also a very avid runner for many years, and I wore my hip bone into a flat surface. It went from being a round surface to being a hemisphere. And
yeah, well,
I really don't know as to say, is it the radiation? I doubt it's the radiation, but the radiation may have accelerated what was already there. The hormone therapy could have accelerated what was already there. I will tell you one thing. The best thing I've ever done is to get 2 new hips.
That's what everybody's saying.
And when the second hip bothered me, I did it right away. When the first hip bothered me, I waited 3 years. And boy, I really suffered during those 3 years. And I was very athletically active during those years. I was like rowing every day. So if you need it, and you think you have a weakness, you should do it. Have you done a bone density? Have you done any bone density scans?
Yeah. Well, I haven't done it again. I'm going to be seeing my oncologist at the end of the month, and I'm going to run all of this by him because maybe I should go for bone density first again because I had one back. I had it back in October, I think. Or September or October, I had it.
Yeah, no, you don't. I would say you probably don't need another one. And what did it show?
It showed fine. My bones showed fine, according to the doctors.
You didn't show any osteoporosis or osteopenia?
No, nothing.
Um,
I'm bone to bone on my hip. That's what
you
the
are bone to
orthopedist
bone.
showed me. Yeah, that's what he showed me. I'm going through physical therapy now twice a week. It
Right.
helps me a little, and I know I'm just buying time. It's just a
Well,
question that my mind has to get into it, and I got to get up the strength to do it.
well, we can talk about that as well. But the one thing I would say, and I got to defer to the doctors on the call, but I don't think you get to bone quickly. If you're bone to bone, you were probably well on the way to bone 6 months ago. And
Right.
if you suffered from arthritis for a long time, what I would say to you is, yeah, it could have aggravated it, but you needed a hip. And it is, make sure you get it anterior. That's the only way to go, from the front.
Right.
And you'll be up and around in a couple of days, and after 4 to 6 weeks, you won't even know that you had a hip.
Okay. Thank you.
I could add something here, Rick, if it's okay.
Please.
Yeah. Yeah, I've had 2 hip replacements within the last 3.5 years. The more recent one was about 18 months ago, maybe 2 years ago. I'm on Zytiga now. I was on it then, and it was really no big deal. My surgeon, I mean, he knew all about my condition, what was going on, and he simply withheld the Zytiga for the week just beginning the surgery and for a few days afterwards. It was not a big deal for him. And I never even thought if this was being any kind of result of the hormone therapy or hormone therapy or anything like that, because I'd been on that stuff for quite a while. If you've got arthritis, you've got arthritis. It's usually not related. But the bottom line is I recovered just as quickly as anybody else. And to Rick's point, get the anterior method. It is a little bit easier recovery. So I
Thank
would
you.
go right ahead and not hesitate.
Jeff, you have a comment.
Well, I had my right hip replaced in September, the end of September, and I've been on ATT for 7 years, and I've had my one knee replaced. I'm ready to have my other knee replaced. I think it's definitely a factor with the drugs we take, but as everybody said, the anterior operation, you get over it so quickly. It's 6 weeks, you're up and around. You're not completely healed, but they say it takes a year, but it really, you're out there walking around and not really in any real pain. It really don't worry about having that done as long as they do it right.
Don Rogers.
Yeah, hi. I just want to mention this. I had 34 fractions of IMRT ending in September 22, and my most recent PSMA showed that I had these insufficiency fractures in my sacrum. So I went ahead and wanted to see someone to talk about this, and so I saw an orthopedic oncologist at the University of Miami, and she ran another MRI, and I'm going to tell you the impact of the radiation on my skeleton has been quite significant. Especially one of the findings, and I'm reading right from the report, osteonecrosis of the left femoral head with reactive edema, probably related to radiation. And clearly the insufficiency fractures of the sacrum were related to the radiation. And so, I wish I had known that at the time, because I think it was almost like a 50-50 chance that I'd have a femoral head issue, because that's leading me right now. I mean, I just think when you got a spot on the head of the femur that's dead, I think I'm going to be a candidate for a hip replacement fairly soon. I have no pain.
Good. I've got a good friend who had the insufficiency thing on his sacrum. He went through hell for several years, and his radiation oncologist, wouldn't put it together. Wouldn't admit, of course they wouldn't admit that caused it, but it was brutal on him.
Yeah, I think I'm fortunate. I'm pretty active. I do a lot of hiking. It presented itself last summer. We were out in Mount Rainier, and normally, I climbed the mountain twice, and I couldn't even get up 1,000 feet. It was really rough back then, but I think it's healed itself, hopefully.
Yeah, sometimes it takes a while because it's like hairline stuff. Yeah. Yes, radiation can do a number on bone tissue. Greg, you have something to say? Greg?
Yeah, I just had to unmute. Sorry, it takes a minute. Well, two things. One, I've had a hip replacement, and I had my right hip replaced, I don't know, 5 years ago, I think, and it it healed. It took a while to heal, but it healed enough for me to build a house, so that was fine. And now my left one could use a replacement, but the problem is that's where a lot of my cancer is, in that bone, in the socket area of my left hip. And the problem is like the doctor, they remount the socket to within a millimeter of smaller than the ball joint, and then they just smash it in, or then the socket, and they just smash it in with a hammer. And mine could split because of the osteoporosis caused by it. It's actually osteopenic, but with the cancer, it's a chance that I'm not going to take, because if I could come out of there with no hip at all, it'd be cut off and I'd be in a wheelchair. So I'm thinking I'm just gonna, but I did find my doctor gave me some good drugs about a year ago that worked pretty well. So anyway, that's my hip story. The other thing, I wanted to change the subject. I just stopped taking, I've been on ADT and abiraterone for almost 6 years. And I just stopped taking the abiraterone about a month ago to see what happens. And I know that Len, I understand,
Greg, with respect, Peter, we have to.
Okay.
If we have
Yeah,
time,
hold that thought, and you'll be next, Greg. Len, you had a comment.
So
right.
We try. Hold on a second. Let me just make sure, because everybody should know this. It's just a point of order. If you come in the first 10 minutes, we poll everybody to see if you need time for the meeting. If you come in after that time, and we have time at the end of the meeting, we will come to you and we will ask you. A lot of times we don't. Today we may do, but what we don't do is we don't allow people to hijack the meeting to their point. So we need to stay on point. So your hip point is fine. Please hold the other one, and we'll do our best to get back to you at the end of the meeting.
Okay, well,
you'll be up quickly.
Hijack is a weird word.
Go
anyway.
ahead.
Well, that's no. It's exactly what it is. When you jump into a meeting and you turn it from what we're talking about to yourself, that's hijacking a meeting. And that's what we don't allow, but we welcome you, and it's important for you to get here in the first 10 minutes. That's the reason why we have that 10-minute cutoff, because we have so many people in this meeting, and if everybody came in and put their hand up and turned it to themselves, we'd never get through. So Len has his hand up, and we know you want to say something, and we hope we'll have time for you. I hope you understand that.
All right.
Len.
So I wanted to ask David. David, I think you said you had bone metastases in your hip. Is that right?
No, I had in my pelvis bone. I
Pelvis
had
bone.
one
Okay.
spot.
Right. And so are you taking a bone strengthening agent?
No.
Okay, you should be by standard of care. You definitely should be taking probably Exgiva, denosumab, in which case you're doing all that you can to prevent further loss of bone, and so there'd be no need for the DEXA scan. But it is standard of care for someone with metastases to the bone, no matter where it is, to be put on a bone strengthening agent like Exgiva or Zometa. So talk to your doctor about that.
Have you had a second opinion? Have you had a second opinion from another orthopedic surgeon to look at this?
No, I was thinking of doing that.
Yeah, I think it would probably be smart to get some other eyes looking at this before you just jump in.
Yeah, it's interesting. I'm going through the PT twice a week, and I feel like it's strengthening, but yet I go out and I walk 10,000 steps a day. So I'm not doing, really good for what they want. Maybe I should just sit still and try to rebuild the strength, the muscle first, and then do all my walking. So,
does it feel like it's bone on bone when you're walking? I mean, does it feel like it's bone on bone, or does it just feel like muscle, weak muscle?
It depends. It depends. Some days I can walk and I'm fine, and then some days I'll take a 2-3 block walk, and by that time I know I'm bone to bone because I just got to sit down before I move on.
If it was me, I'd shop around and get another opinion from some good orthopedic surgeons and really take a good look at this. If it's time, it's time, because you'll do. I mean, everybody I've talked to who's had success with is it's a miracle. I mean, this is a miracle of our time that we can replace hips. It's pretty incredible.
Yeah, that's all I hear. Is I hear a lot of positive stuff about it. I hear a lot of good stuff about having the hip replacement. And my daughter's a doctor, and she's for it. She, when I went into the orthopedist and I came back with PT, she almost killed me. She said, "Why didn't you schedule your surgery and just get it over with?" And she knows my whole case and everything. So
okay,
I think, in essence, I know I'm eventually going to have to do it because, the PT is just, it's helping, but it's not going to cure it.
Okay, well, get some opinions from other orthopedic surgeons and see if you can get some energy on this one. Okay, well, thanks very much, David. Jack, you had something you wanted to bring up this evening.
Thank you. Yeah, I was sort of an early bird, but the significance of, I guess, my situation relative to a lot of other members is minimal. So maybe I feel it's okay if you want to pass me. But I'd like to share my visit yesterday with my medical oncologist, Dr. Bilusic, and just to bring everyone up to date. I've been on darolutamide now for 10 months and Relugolix for 8 months. And my PSA is undetectable, as is my testosterone. And my DEXA scan showed my left hip shows some osteoporosis, mild, fortunately. However, the thing that concerns me most of all seems to be the sort of volatility of my blood parameters. My white count, went down to 2.4 4 or 5 months ago. Then it went back up to 4.5, and now it's down to 3. My hemoglobin also jumps around, a lot of lability there, and now it's as low as 13. I can feel it because I run close to a 16 normally. My hemoglobin, my absolute neutrophils 2 months ago were 2.67. Now it's 1.65. And my fasting blood sugar on 250 milligrams twice a day of metformin that I put myself on went down to 94, and now it's back up to 105 in spite of the fact that I'm on metformin. So I'm a little confused. He said to me, it's a little metformin, bump it up to 500 twice a day. So starting today, I'm going to do that. So that's where I'm at, and I just wanted whatever feedback you can give me, you veterans who've been on darolutamide for such a long period of time and understand the drug more than I do, and also whether you experience that kind of volatility up and down. 1 month you're recovering, and the next month you're regressing, and whether or not that's par for the course, and whether the fasting blood sugar, in spite of you, I think Len told me you took metformin once, and I don't know if you said whether or not it was beneficial or not, but I sort of wonder if you couldn't talk about that with me.
I'm sorry, Jack, did you say that I said I was on metformin?
I think you said you gave it a try at one point with the darolutamide. No?
No, never did. But your doc's advice to take a higher dose of metformin sure makes sense because you were on a very low dose.
I know. I thought I could get away with it.
Yeah. That's smart to do it that way.
Well, I'm just being prophylactic. I don't like pre-diabetes.
How's the A1C, Jack?
My A1C is 5.4. But
good.
Yeah. So I don't know. Maybe that just happens. I was absolutely fasting yesterday, and I had tofu the night before, so I thought for sure I could go for a low blood sugar. And during the Super Bowl, I didn't have any chips.
To answer your question about white blood cell counts jumping around, I have not experienced that on darolutamide. Maybe Peter, have you?
No, not particularly.
How about hemoglobin?
My hemoglobin's way lower than yours.
And
mine tends to be in the high 12s.
What was your baseline before you started treatment?
Oh, probably about 15.
So you just live with it and just do you feel some exhaustion, fatigue, and shortness of breath?
Shortness of breath, yes.
Yeah, I noticed that. I never had that before. And I just thought I'm out of shape. My VO2 max is down or something, and this hemoglobin thing, I think definitely is a factor because I work out and I do all the other things, but I don't know how to get my VO2 max back. And I don't know how to get my hemoglobin up. So he said to me, hey, time. You know how to get your hemoglobin up as a result of these drugs? Anybody have any ideas?
Well,
no, there's no use taking iron or anything like that. You just got to wait till the cause is gone. I'm like Len. I run in the very high 11s and used to be much, much higher. But I think it has to get lower than that before we're symptomatic, doesn't it?
Yeah. Usually, if you go do
bad.
chemo, it's going down to 8 or below.
That's what I thought, yeah.
I had my
Dr. Jack.
Yeah.
Dr. Jack, I cannot remember, I should look it up on my notes here, but are you on monotherapy darolutamide?
No. I'm taking Orgovix. I've been taking that
so
8 months.
So one thing that I would talk to Dr. Bilusic about is maybe monotherapy darolutamide and see how you do and stop the Orgovix.
I spoke about that yesterday because I know a lot of people have been doing that. He said to me, let's go 2 years on both and then we'll talk about the darolutamide alone. So I've got another, 14 months or whatever it is, 15 months.
So, I think the response that you're seeing is what we would expect. I had that response when I was on my hormone therapy, on my LHRH. And I think most of us who are on long-term LHRH, that is how our body responds to it.
I mean, the
Can't do much
volatility,
about it. Sorry?
you had that volatility up and down with your blood.
I can't remember if it was volatile because this is a long time ago. But
Yeah.
I can't remember if it was volatile. But I do remember that my blood counts were all marginal at the time, and I don't know that they jumped around that much. But then I don't know that I tested them that often to know if they jumped around that much. I tested my PSA and testosterone monthly because that was the Kaiser protocol at the time. But the whole blood counts, no, we didn't do that. But I think that if you ask most of the gents who are on here, they've all experienced this marginal aspect of their blood counts. That they just go down, and I don't know how. I mean, is there anybody on this call whose blood counts are as good today as they were, and they're still on HT and they're on hormone therapy? Anybody have the same level of blood counts as they did before they started the HT?
No way.
Nope.
No way.
And then there's all my friends who are the common sense people who keep saying you got to eat some meat. Stop with the tofu and the fish.
No.
And I say,
No.
I don't have that
None
kind
of
of
that works.
I think
Prostate
you lay
cancer
this.
likes meat.
more beef in your system. Eat some pork.
No, I think you have to tell them that you have to lay this fairly and squarely at the doorstep of the hormone therapy.
Yeah.
And once you stop the hormone therapy, it's going to improve. And I tend to agree with Dr. Bilusic. If you can get through the first 24 months, Jim Ward was on this call before. I don't know if he's still on this call, but we had to provide a heck of a lots of support to Jim to get him through. But he got through, and then he stopped it. I think, could you stop after 18 months? I think you're open to discussion. That was something that we heard earlier on in this call. I think you might be able to revisit with Dr. Bilusic in 4 months. And especially if you say, look, can I see if just dropping the hormone, the LHRH makes me feel better and will stay on the darolutamide? He may be open to discussion. But I think that rather than making yourself sugar over these blood counts every regularly,
Concern,
you just got to say, this is it. This is what I got, and it'll come back.
Okay.
You're going to be with us. How old was your mother? I can't remember. 102? How old was your mother?
She died at 101.
Excuse me, 101. So I think you're going to be with us for a long time.
Well,
so, you'll get through it, and then you'll be Superman again.
I'll be very grateful in my late 80s, or if I make it. I'm 84 now. I'll be 85 in August. So
yeah, Great. But you'll be like Alan Babcock. He's left now. He can't hear me. But you'll be like Alan Babcock. You'll be 84 going on 70. Just like Alan Babcock, 75 going on 60.
Some people say 60 is the new 50, and 70 and what is it? 70 is the new 60, but 80 is fucking 80. And there's and believe me, it's a big difference. 80 is very different than 70.
Jack, there's surprises that can happen even at 80 or whatever. I'm not far behind you.
Okay.
I mean, I did a blood test at the beginning of whenever it was, I don't know, 3 weeks ago or something like that, or 4 weeks ago. My hemoglobin came back at 11.4. That's the highest it's been in 6 years.
That's great.
6 years. And my hematocrit, same thing. My red blood cells hit 4.02. And then they were normal level, low normal, but normal level. That's the first time they've been above 4 in 8 years.
That's great.
And I don't know what made it happen. And I've been on and off. I've been off of ADT for well over a year now, off of darolutamide for a long time now. And all of a sudden it just jumped. So who, God knows, but my hemoglobin was down to in the low 9s for years and years. When I was on
And
chemo, it was down the low 8s.
I think that Herb Courtney, who has left unfortunately, would take issue with you because he's also 86 and he's unbelievable. So he might not agree with you. Len, you've had your hand up for a while.
Right. Well, two things. First, let me address Peter's boost in hemoglobin. It could be from the immunotherapy.
It could be. I don't know. Could be.
But
nobody.
Yeah. Okay.
No answer to it.
I wanted to ask Jack if he's had a pulmonology workup for the shortness of breath.
No, I haven't had a pulmonology workup. No.
Okay, because I did that, and they discovered I had interstitial lung disease, but they weren't sure if it was serious enough to cause my shortness of breath, but certainly doesn't help. And of course, there's nothing they can do about it. So, except maybe you'll find out why you have shortness of breath.
Well, relative to, some days I don't have it as much as others. Peter, you're 80? Peter.
Me?
Yeah.
No, I'll be 77 in a few months.
No, you said, you sounded like you were implying that surprises happen. People.
Surprises happen, yeah.
80-year-old, so I just wondered if you were 80.
No, I'll be 77 this year.
Okay, gotcha.
Dr. Jack, are you on tamsulosin?
Say what?
Are you taking tamsulosin? Flomax. Flomax.
No, why would I?
I don't know, because I don't know how, if you pee okay, you don't pee okay, but
my hair?
I'm asking.
Why my hair is?
No. I'm asking if you take tamsulosin because a little known side effect of tamsulosin, which is Flomax, which a lot of guys are on, is shortness of breath.
Well,
and I just wanted to make sure you weren't on tamsulosin because that could have been a cause of your shortness of breath.
Right, but I would need a prostate to be taking that because I lost my prostate 21 years ago when I had the surgery, and that's usually taken for BPH, isn't it?
It's also taken. It's also taken for bladder issues.
No.
In fact, it's more likely to be taken for bladder issues than for BPH. It's a bladder drug.
Didn't know that.
Jack, that reminded me of a song. I lost my prostate in San Francisco.
Is that how it goes?
I think that's how it goes, doesn't it?
Boy, you're in good spirits. I'm sure that laughter will make your hemoglobin go up even more. Okay. Thank you, guys.
Greg, go ahead. We have a few minutes, Greg. There you go.
Yeah, thanks for letting me speak here. Like I was saying before, I was on ADT plus abiraterone, Lupron plus abiraterone, and I stopped taking the abiraterone a month ago to see what happens. I'm still on the Lupron. I just had a Lupron shot actually, because I kind of wanted to separate the two and see what happens just when I stop the abiraterone. And I was just wondering what other people that have been on holidays, if they've done it this way or if they've stopped everything all at once, and what results after how long.
Usually the holidays are person, let's say, might have gone on hormone therapy after an RP and be at high risk. They might go a couple of years, and they usually stop both drugs at the same time.
Okay. My MO just said, because when I was talking to him, he says, yeah, just stop the abiraterone for now. I mean, I've been on both of them for 6 years. I have metastatic bone to the bone. And but I've been on, my theory is I've been on it for so long that I don't even know if my body would produce testosterone anymore. Certainly not from the testes, at least not in any great quantities.
It
Um,
might
so,
indeed take quite a long time for testosterone to come back if you
Yeah.
stopped your LHRH drug and your abiraterone. In my case, for example, I've been off meds for about 1 3/4 years, and my testosterone hasn't come back yet. And you're much longer than me. And the length of time you've been on ADT is one of the predictors of whether it's going to come back or not.
yeah,
Another
exactly.
predictor is what your testosterone level was like before all this started.
Yeah, I don't know actually. I might have to look back on that and see if I can find it. I don't know if I'll even be able to find it.
So it might
I,
indeed be quite a while. Maybe you'll be lucky and it won't be.
yeah, well,
Well,
that's a two-way thing. Lucky,
That's
and it won't
that's
be.
right. That's right. Yeah, which is lucky, right? Yeah.
Yeah,
Rick,
yeah.
what were you gonna
yeah,
clarify?
well, a couple of things. I mean, your testosterone doesn't have any chance of coming back whilst you're on an LHRH.
Right.
Most times when people give up a drug, and they're on both drugs, they give up the LHRH.
Yeah.
So that allows testosterone to come back into their body, and that may help them feel a lot better. Even though the abiraterone might work against it, we've seen guys do way, way better stopping the LHRH than the abiraterone. My guess is that your medical oncologist is not a GU medical oncologist. Is that right?
No, he's not.
So you need to get yourself to a GU medonc. I don't know if I'm not sure if you've come into this group before, but we're happy to give you enough time to tell us your whole story, and to counsel you. But the first thing I think most of us would say is get yourself to a GU medonc, because a GU medonc wouldn't have you, if you were going to give one up of the two, the GU medonc would have you give up the LHRH.
Yeah.
Because that might make you feel better.
Yeah. Well, like I said, I just wanted to see, like, the abiraterone is responsible for what, about 25% of the testosterone?
At the most.
Like
Yeah.
most. Yeah. So I would just want to see what, a lot less,
Yeah.
like approximately how much?
Very little. But
10.
because I don't know the percentages, but I think the point is this. We've seen gents on abiraterone monotherapy. And
Yeah.
we can tell you that those gents on abiraterone monotherapy have been able to maintain and do fine. And they felt much better, even though their testosterone has come back. Other option is to switch from abiraterone to an androgen blocker, receptor blocker, and to stop. But to see how you feel and continue to take an LHRH, yeah, it may be slight. You may have a little less fatigue. I could see that. But I don't think anybody here who has tried to manage their hormone therapy strategy has ever given up the second line anti-androgen and maintained on the first line anti-androgen. Let me go to Len, who has his microphone on.
Well, first, let me address the abiraterone testosterone equation there. Of course, abiraterone will stop testosterone production no matter where it is. And whereas the LHRH will block the testes only. So the ratio there is 85% was blocked is coming from the testes, another 15% from the adrenals, and abiraterone blocks both of them.
I thought abiraterone just blocked the adrenals.
No, It'll block testosterone no matter where it's being produced,
Okay.
even if it's being produced by the cancer cells itself.
I guess that's why some people do okay on monotherapy with abiraterone.
Yeah.
Right.
Well, I didn't intend to take another Lupron shot next time and see what happens.
Where are you being treated? Who's your doctor?
BC Cancer.
Oh, you're in British Columbia? You're in British Columbia?
Yeah.
Hmm. Yeah. I'm
We
not
have
sure.
a GU person there?
Oh, I'm sure there is.
There must.
Oh, yeah, I'm sure.
They must at the university. They must at the university.
Well, BC Cancer and the university work together.
Okay. Well, there's got to. Yeah, that's being on 6 years is a long haul there.
Yeah.
So do we have your email? Is this your first time on our call?
No, I've been on a couple other times, but I haven't said anything. Well, actually, I did once, but anyway.
Yeah.
Try and get here. Try and get here at the beginning of the call, and then we'll know you're a new guy. We'll give you priority at the beginning, and we'll go through. You know, there's a terrific doc, and I think he's at BC Cancer. Is Kim Chi?
Yeah, but he's full. I tried getting into him, and he's full.
Well, but he has other GU medical oncologists who work with him, so you have to find out who they are.
Okay.
I can't remember off the top of my head, but there are other GU medoncs who work with him because I've seen them on the research. And so, you know, rather than being with a general medical oncologist who's really guessing at how you should best manage your hormone therapy, I think that's a good place to start.
Yeah, that's probably a good suggestion because you're right. He's guessing.
Yeah.
Right.
So he's not an expert on prostate cancer. A lot of the things I bring up, he goes, "Oh, I don't know anything about that." I go, "Oh, really?"
Right.
So,
Yeah, the 6 years part is not typical. The getting rid of the Abby and staying on the other drug is not typical of what we see from the GU medoncs.
Okay.
What treatments have you had? Surgery and radiation, or just one, or?
No surgery. I had metastatic at my diagnosis, so
Okay.
I just immediately went on the 2 drugs.
So all you've done is LHRH in second line.
Yeah.
For 6 years.
Yeah.
What's your PSA?
Last time it was 0.053.
Well, that's good. So you're still sensitive. That's good.
Oh yeah, no, it's going fine. I mean, you know, it was undetectable for a couple of years, and then it's slowly gone up to 0.053. But I mean, it's still really low. And I get all the tests done at the same lab. So.
And what's the game plan? What are you thinking if you lose sensitivity to it? Do you have any idea what's next?
No, I'm really not a fan of chemotherapy, so I don't know if I'll be doing that or not.
Well, stick your email in the chat window so we can keep in touch with you. And it's an interesting story.
Where's the chat window?
Next to the little thing with the person, it says 28. There's a little two little squares.
Oh yeah.
They won. Yeah.
Okay.
Yeah. I know Canadian health is a little bit challenging. At least you're in the Vancouver area, which is a positive.
Yeah, no, BC Cancer is very good. It's just you have to, I guess you have to know a little more about how to navigate it. Like I had a urologist at first who found the cancer. Well, I knew I had it. I just went into him. He told me, and but he was not the greatest guy in the world, so I dumped him, and he referred me to this guy who, is not he's just a general MO. So I wasn't on the greatest terms with my urologist, so he wasn't into really helping me out too much.
So
Well, I think what you've got to do is go back to you've got to go back to BC Cancer and ask who the genitourinary medical oncologists are other than Kim Chi.
Yeah.
And I know there's more than one for sure. There's more than Kim Chi. I'm trying to find their names. I'm trying to remind myself, but because now Kim Chi heads up BC Cancer. He's the chief oncologist there. So, but I'm sure that they will tell you who else, and you need to get. If it were me, I would be with the GU medonc at BC Cancer.
Yeah. No, I will definitely look into that, and maybe I'll try and get a referral back to Kim Chi again, just in case he happens to have a spot. You never know.
Yeah.
Try.
It's like rolling the dice.
Yeah.
Yeah. I mean, he's really good. This might be a lead. Let me see. I'm working the computer as I'm talking to you and trying to see if I can find the names of the names. But if you put your email in, and if I do find anything, or next time I see a name in Canada, there are some other guys. There's a couple of guys at Vancouver Cancer Center as well who are GU medical oncologists.
Vancouver Cancer Center?
Yeah, I believe. I think it's a separate entity because we discovered this recently, that Vancouver Cancer Center is a separate entity to BC Cancer Center.
I've never heard of it.
Okay.
I'll check into it. Okay, thank you.
Thank you. Yeah, keep in touch with us. Okay, guys, anybody else have any parting comments or we didn't get to or I missed or anything?
What about you, Peter? We didn't get to you.
Yeah, we didn't get to you, Peter. We said you should start. We've got 10 minutes.
I don't want to keep you guys from doing your Valentine's Day shopping. Okay.
You mean going to Walgreens the night before Valentine's Day, right? That's what most guys do, I think.
That's what my dad did, but he died of prostate cancer.
I just have to tell you that that Dr. John took care of business. He did. He went out and he bought chocolates for Ray, and Ray bought chocolates for him. The only problem is the chocolates he bought for Ray, they were called Breakup. I said, are you sure that's what you want to give your wife? Chocolates called Breakup?
Okay, quick story. So I won't go into it all. As I mentioned to Jack a little while ago, the last blood test I had great results for my CBCs. Hemoglobin up, hematocrit up, first highest it's been in 6 years. Red higher than it's been in 8 years. Pretty amazing. And I test every month. I've got records going back every month in the Excel spreadsheet to look at for every month for 8 years, 10 years. So, but my PSA jumped. It doubled. It went up from, it had been hanging around 0.8, 0.78, 0.79, 8 for about 4 months. Then it jumped up to 1.99. I'll do another blood test in a couple of weeks on the 26th and see where it is. I'm not panicking. I did do a PSMA scan. As I intimated in my reminder notice, I had it was ordered by Dr. Schultz in California, and I did it here in Honolulu. I had to fly over there on my own dime and do it. And I sent over my disc from 2 years ago from El Camino Hospital, and they did a scan-to-scan comparison. And yes, my tumor tissue in my peritoneal cavity has decreased significantly. They picked up on that right away. They didn't do it when they looked at the written reports. That didn't show any kind of decrease or anything, but when they looked at the scan, it showed a decrease. So that's what Schultz asked me to do. And then Schultz had another kind of crazy idea, which I had never thought about. And he said, well, why don't you do radiation? And well, just nip it in the bud. The only place you have is these places in your peritoneal cavity, which is kind of odd for a guy. It's common for women with uterine cancer or ovarian cancer. So I had a phone appointment with the head of radiation at UCLA, and it was great. And he and we talked it over. I talked to his PA, and I talked to him, and he said, if it was me, I would not do radiation. I don't think this is a good idea. In fact, I'm going to talk to Dr. Schultz and talk him out of thinking this way. So he said probably I should go on watch the PSA. If it starts climbing significantly, go on a PARP inhibitor, which is what my doctor in Minneapolis, Dr. Antanarakis, is thinking too. He's been thinking for a while. My thought had been to go back on Keytruda, but because of the reaction I had to Keytruda at the end with intestinal stuff going on, which he diagnosed as immunocolitis, which is why I went on prednisone, high-dose prednisone to knock that out. Anyway, I'm doing pretty well, feeling good. My energy's up. I'll do a blood test in a week and a half and see where things are, and start talking getting some other opinions and see where I am. But that's the short story of it. I'm feeling good, feeling energy, and I'm not overly concerned about this. About my PSA jumping. I can live with this for a while and see where it goes. One thing I talked to Rick about, I have a study that was done that Antanarakis actually did. I think it was done in 2019, I believe, which was a phase 2 study of olaparib without ADT in men with biochemically recurrent prostate cancer after a prostatectomy. And half of them had an HRR BRCA2 mutation, which I have a somatic BRCA2 mutation. So anyway, I'm going to talk to him about that, because I'm not anxious to go back on ADT. I've been off it for a while, and just see where things go. I'm open to discussion with these docs, but I'm not chomping at the bit to do anything right this moment. So that's where I am. I just sent away a couple of days ago to Garden 360 for another liquid biopsy. We'll see where that comes back. I talked to Rick about why we're not big fans of Garden 360, and I can already see it because I called Garden up to ask them if they do an MSI test, and they said no, they don't do that. So, which is important for me because of my germline mutation. So that's the short story of it. It doesn't apply to most of you, but that's kind of where I am.
What is your testosterone level, Peter?
It dropped down to 50. It's been 90, 100, 50. It hasn't gone below. Well, once it went to 30, it's kind of low. But I've been off of ADT for a year and a half, so I don't know. It hasn't gone over 100 yet. But
Peter, the one concern I have, provided your cancer is still adenocarcinoma, is totally avoiding hormone therapy. I mean, a monotherapy second-line anti-androgen may work, but to forego all hormone therapy would bother me personally. I don't know what the opinion of the other people in this group are, given your situation, especially the moderators, but it would really concern me now that you're off the other treatments to still stay on a hormone therapy holiday, whatever treatment you do.
Yeah, that's a discussion for sure I'll have with the docs. I meet with the brand new one here week after next. But we'll see.
Peter, the ASCO GU 2024 conference had published a study. I think they called it BRCA, BRCA, like BRCA and away, where they compared Abi alone, olaparib alone, or the combination. And the combination of Abi and olaparib did significantly better than either one of the other two alone.
Good point.
So
Well, these are for sure discussions I will have with enzalutamide, which probably probably will lead to my next treatment decision, is my guess. But we'll see.
Well, the other thing that's going to help the next treatment decision is are reliable somatic tests.
Right. And I'll get the results of that, I guess, in a week or two. I don't know, and we'll see where we go. And I have an appointment with Schultz at the end of the month, and I'll talk. That'll be in the conversation with him. Yeah.
Anybody else have anything?
When I was with Jeffrey Turner, he ordered a foundation medicine and a Caris test for me. But for some reason, Schultz went to this one. So I have no idea what the politics are in that.
Yeah, I mean, the reason, if anybody's wondering, the reason we don't like Guardant is based on advice from a couple of our very reliable GU medoncs, including Dr. E. And I guess I put weight on that. I don't need them to explain to me why. If they say I wouldn't use it, it's good enough for me. So
the fact that they don't do MSI testing is significant to me.
Yeah, I mean, maybe that's why he doesn't use them. She was in touch with me this morning. We are actually writing a letter of endorsement for a study they're doing in Houston. We may get Julian involved in this at some point, but they are trying to get a grant from Movember to provide better support across some 70 low-income clinics in Houston, especially to Hispanics and African Americans. So I don't know exactly what she wants from us, but sometime before I go to bed tonight, I've got to take the edited text and put it onto AnCan letterhead and send it back to them. But anyway, I do think a lot of this is going to be whether, in fact, you still show BRCA, somatic BRCA. You may not show somatic BRCA this time.
Or if my PSA kind of hangs low, who knows? We don't know where this is going. But I'm not nervous. I'm doing okay. I'm a happy camper.
Okay.
Take it easy, guys. Good participation.
Next week, it's Len. It's Len in the hot seat. Len will owe me an introduction. Just saying.
Hopefully on time.
Hopefully on time. Len will owe me an introduction, and we will be meeting next Monday night, which is Monday it's President's Day. Okay, I'll have to get Bill Franklin in for that one, since he's our president. We'll see you next week, and wish you all a good week.
Take care. Bye-bye.
Take care, guys. Bye-bye.
So,
great job, Peter.
Thank you from Thomas.
Okay, Thomas.